All right, welcome everybody. It is the March 28th, 2024 Board of Health meeting. It is 12:37. We will call the meeting to order. We'll start with a roll call. Can I ask Ann for assistance?
Commissioner Josh Kearns.
Here.
Commissioner Amber Waldreth.
Present.
Councilmember Michael Cathcart. Board Member Monica Blakowski-May.
Present.
Board Member Charlie Duranona.
Present.
Board Member Patricia Keimholz. Here. And Commissioner Cooney had an excused absence.
Okay, thank you. Please keep only 6 microphones on at one time, and if you're not speaking, please mute your microphone. But we did have public comment that is in the packet as well. That will move us on to our board reports. So committee reports. We'll start first, finance, budget and finance. Commissioner Waldreth, can you give an update on what was discussed in budget and finance this month?
Thank you, Mr. Chair. We had myself and see who else is on the committee, Patricia and Commissioner Cooney, and we discussed some different items that were coming before the board on our agenda today, including several contracts. And we really just had a good overview and training on how the Spokane Regional Health District budget works. What are all the different funding streams that come in from the state, the federal government, local funding? So that was really helpful. So thank you, Kim, for giving us the budget 101. So as a committee now we can be more knowledgeable about when different dollars are coming in, the cash flow situations. We looked at the reserves. So everything is looking good so far year to date, and so I'm sure Kim will give us an update today. But yeah, we're looking forward to having kind of level setting and knowing where we're going as the year progresses.
All right, thank you. Councilmember Cathcart, anything on the Policy and Education Committee?
No, not at this time, but we are trying to get some meetings set up for the remainder of the year.
Sounds good. Okay, and then the Executive Committee also met this month and mainly just focused on going over the agenda and getting everything prepared for today's meeting. Next, that brings us to item number 4, which is the consent agenda. We do have 4 items on here. Is there anything that anyone would like to take separately from our consent agenda item? Which is item number A, are the meeting minutes from February 29th. B are the vouchers for February. We do have 2 contracts on there as well. So if nobody would like to take anything separate, is there a motion to adopt the consent agenda as presented?
So moved.
Second.
All right, we have a motion and a second. Any comments? Questions? Seeing none, all in favor say aye.
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 Aye. Motion passes unanimously. That brings us to some executive session items, and so I will look to our legal counsel to state the purpose and those she wishes to be in attendance. Okay, at this point it is 12:41. We'll give just a couple minutes to clear the room. So we're going to say we will begin executive session at 12:43. And as stated, it'll be for 30 minutes. So we intend to come out of executive session at 1:13. If we do have a reason to extend, we will make that announcement. All right, we have concluded our executive session. We ended at 1:13. We did not extend. Just took us a few minutes to get the AV equipment up and going. It is now 1:15 for the record, and that brings us to our first action, our second action item of the day, which is item number 6A, which is to rescind the treatment services record management decision made at the June 29th, 2023 Board of Health meeting. And Dr. Thompson, you have a presentation?
Yes, well, the paperwork is in the paperwork is in the folder. We didn't make slides for it. It looks like it's the section of papers that looks like minutes, but it's highlighted on the second page. So I'll wait till everybody has found that. Okay, now it should look like this. Keep going. There we go. There we go. Does everybody have it yet? Okay. Okay, so on the second page, you can see the highlighted decision that the board made, which was to go with to approve option 1 to catalog and scan treatment services records. And so what is option 1? If you turn 2 more pages, you're going to have a highlighted, actually it looks like 3, you have the S bar when this was brought before you, and on the page 2 of 3 of the S bar, again you have a highlighted yellow line which states option 1, vendor scans on premise at the College Avenue building. And at the time that this was being discussed, there was a belief that it was a requirement to scan all of our older paper records. We have not created any new paper records since 2021. The paper records that we currently have are discharged clients' papers, and we have some active files of patients that now have an electronic health record, but they've been clients with us so long they still have a paper chart. And so the belief was that we had to get all of those scanned. And the cost to scan those records is very large, somewhere around 90, 100,000. We were gonna go for a grant with the Washington State Archives for 50,000 to help pay for it. But as we were talking with the Washington State Archives, they were like, well, we really like to archive things that must be archived, must be scanned and archived. So I had conversations with that employees higher up regarding, do we have to scan these files? And I did further research. I could find nothing to document and say, and I know all about meaningful use and high tech and all of the laws that brought us to our electronic health record world that we have today. And there is nothing. And actually, we had an audit of treatment services, and one of the audit findings was that the files are here and treatment services is there. And so what I would like to have happen is to have a moving company move all of those patient files from this location to 8th Avenue. We will go into the incident command structure for this event to ensure that we have a solid, clear chain of custody on those records. We will ensure that we always have eyes on every single box, every single file cabinet, and it will be professionally done. It's not going to be employees picking up boxes and breaking their backs. It's going to be a professional company. And that's going to cost us around $1,200. And there's space over at the 8th Avenue building where these files can just naturally age out. And as they age out, they'll be destroyed per the public records requirements. And they'll be where they need to be, which is where treatment services is. And so in order to do that, though, I need to ask you to rescind this decision that was made requiring that these files be scanned electronically and kept here on site. Yes.
Any questions?
Yes.
Go for it.
Dr. Blakowski may. They're actually going to be more accessible, because that was what the finding was in the audit, is that the files are here, and so treatment services was having to call someone here that really doesn't have a need to know what's in any of those files. They were having to go into those files, find the piece of paper, specific piece of paper that they were needing, and then that individual would scan that piece of paper, send it encrypted back to treatment services. So now when they're over at treatment services staff will just go get what they need and everything will be good. Well, the discharged files, 11 years. Yeah. We'll keep those until they're no longer active. Any other questions? Go ahead, Ms. Steve. 34 file drawers. There's cabinets, yes, they're file cabinets. I believe it's 13 file cabinets. Some are 4 drawers, some are 5 drawer. In all cases, the top 2 or top 3 files will be boxed up using the appropriate process to ensure that the files are maintained in order. We'll know exactly what's in each box, but the top 2 or top 3 drawers will be emptied. The bottom drawers will be taped so that they can't fall open during transport, and the movers actually have moving dollies that they use to move the file cabinets. Yeah. And we've identified staff already who are having assignments where they will be stationed. We have people assigned to the job of being the person that walks with the moving company mover with that particular load. There's a person assigned to stay with the truck to keep their eyes on everything that's been moved into the truck. The person that goes with the mover back to the filing room. There's always somebody in the filing room keeping eyes on all of those files. We'll have a sign-in sheet. We're having a briefing the day, if you say yes, we're going to have a briefing the day before to ensure everyone knows what their assignments are. Everyone knows what their responsibilities are. Our HIP privacy officer is going to be the safety officer in our ICS structure. And so she will be on site during this entire process so that she can be going around making sure that everything has been being done airtight. And we also have our FEPR team. Robin Albrandt is going to be observing this process because it will be like the first time we've done an operational event like this using ICS and the ICS forms. And so it's a somewhat of an exercise using a real event.
So that just to follow up then, you said that we've been digitizing everything since 21, so most of these were pre-21?
So what I said is we haven't created any new paper charts since 2021. So all charts, every single patient has an electronic medical record since 2021. And so what's remaining are the files that we still had. We have digitized a lot, but it's a massive piece of work. They will continue to digitize. So when that piece of paper comes out of a file, it's getting digitized into their electronic medical. And depending, would you like Misty to come up and talk about plans for continuing to digitize? They do plan as they're able, and as they're able to work into the workload, to continue to digitize the active files. Discharge files, they're just going to sit there. They're going to wait to age out, and then we'll have them destroyed. So I look at it as, because I'm always very concerned about the use of taxpayer dollars, so I look at $90,000 to have these records digitized by a company versus $1,200 to just move them over to where they need to be.
No concerns as far as space constraints up at the ATHAF building?
No.
Okay. Any other questions? Okay. Is there a motion on action item number 6?
Second.
Okay, we have a motion and a second to rescind the treatment services record management decision made at the June 29th, 2023 Board of Health meeting. Any further comments? Seeing none, all in favor say aye.
Aye.
Aye. Motion passes unanimously.
Thank you.
Thank you. That brings us to our reports, which is number 7 on our agenda, and we will start with the administrative officer report.
Yes, hi. I'm going to talk about, I'm only going to talk about one of these things, and then I'm going to turn it over to Wendy Brizendine so that she can address the second item. Hidden in plain sight, I believe we have a flyer that looks like this. This is one of the things that our Healthy Living program does with Amanda Duggar. And you have to be 21 years or older to participate. And this particular session is specifically for elected officials, school superintendents, individuals that are working with youth. And what it is you go through this mock bedroom and you try to identify all of the warning signs that could indicate that your child is involved in perhaps fentanyl or, vaping, marijuana, illegal substances, basically. And so it's I've never done it. Later in the day, it's being done for SRHD staff. And so I'm definitely going to do it. I don't have any young children in my life anymore, but it sounds fascinating to me. So I would encourage you to save the date for this hidden in plain sight, because it is for this particular session is for key leaders in our community. So I strongly encourage you to come to that. And with that, I am going to turn it over to Wendy Brizendine so she can share with you the work we've done on getting the word out about our treatment services programs.
Thank you, Dr. Thompson. Good afternoon. My name is Wendy Brizendine, and I am the Community Relations Coordinator for the Treatment Services Division here at SRHD. Dr. Thompson has shared that the board requested to explore more options on making the treatment services opioid treatment program more visible to those who may need us. After meeting with the communications team to develop a marketing campaign for in the future, my director, Misty, and I started discussing outside ways to reach out within my position at very little cost. Our goal was to become more visible to possible patients by putting information in easily accessible areas to connect with them and meet them where they're at. Our team spent several weeks showing different images and verbiage with our current population, asking their opinion on what spoke to them, what verbiage would make you comfortable seeking us out for help. As you may be aware, stigma can have serious effects on individuals thinking of seeking out. Internalized stigma can lower self-esteem and lead to feelings of shame and guilt, and will often stop individuals from seeking outside resources. With that in mind, and some patient feedback, and some outside-the-box thinking, I designed some proofs to visualize our ideas. The idea was then shown to Dr. Thompson, and she asked me to present this to you. The idea behind these flyers are they will be half and full-page flyers or posters printed to catch attention and be hung in bulletin boards in grocery stores, pharmacies, and other businesses around town, as well as our community partners, all located in centralized areas to catch attention of individuals seeking assistance with opioid use disorder. Several will be placed downtown, as well as being visible in our rural areas, such as Airway Heights, Deer Park, and Meade, as we have individuals seeking our services as far out as Grand Coulee and Colville. Our patients voiced that the images of people facing toward a sunny horizon made it easy to put themselves in that position, to look for a future with hope. Recovery is most often a difficult journey, and not one always filled with smiling faces. But in showing all varieties of life finding their strength and proving that they are stronger than their addiction, it was so important to our program that our patients be seen, that their voices are the ones being heard through this campaign, and that their ideas shine through to others. These flyers will be changed out periodically as to avoid sign blindness and to keep people from looking at them once and passing them by. If you've noticed, I also created a custom QR code with our logo integrated into it. If you scan this code with your phone, it will take you directly to the treatment services landing page on the SRHD website to make us easier and faster to find all ways to get a hold of us. The last part of this is 2 different takeaways. The first one, as you can see, you all have an example, will go on the bulletin boards with these flyers, just like this in a big grouping. The added benefit of having this takeaway accompany the flyers is it's possible to assess how many are being taken and if our flyers are being effective. The second key tag will be a takeaway to give to community partners along with our flyers so that they can offer to those that are seeking us out. That also contains our QR code along with all these flyers. In doing this, we hope to reach more of our population and help them feel comfortable coming to us and seeking out help. I want to thank you for your time and look forward to any feedback you may have, and I'm happy to answer any questions. Thank you.
That brings us next to the financial report. Kim, take it away.
Good afternoon, everyone. I have two financial reports today. We're going to talk about 2023 and how we have closed up the year, and then I'll move into our February 2024 report. So they're both in your packet. The first thing I want to point out for everyone's benefit is we call these SRHD funding and expense reports. They used to be called revenue and expense reports, and we're trying to really make a point that the health district really doesn't generate revenues. There's not a lot of things that we can do to, sell widgets and bring in income. So we really are tracking the different funding streams. So we use a conscious effort to use that terminology. We track our funding, and then we have the appropriate expenditures. So that's why they're appropriately labeled. And in 2023, we closed out the year. We had $53 million in our budget, original budget, and then we closed out the year at $50,825,000. So we actually had 96% of our funding as anticipated. So 96% came in compared to our expenses at 95%. So overall, as an organization, we actually had a fund balance increase of $773,310. And that's reflected in the lower section of the report. Our overall reserves, we have unassigned reserves, and our goal is to be at 20% of our budget. And so with that surplus going back into unassigned, we're at 23% is how we're closing the year there. A couple highlights related to the funding for the year 2023. The first two line items under under funding, our federal indirect grants and our state grants. The federal indirect grants came in at the far right corner. You'll see is almost 85%, and that's okay because the majority of our indirect federal grants are expense reimbursement. So even though we didn't spend out 100% of what we anticipated in the budget, 100% of those expenses would have been covered. So to the extent we had expenses, we were able to bill for revenues. There's very few exceptions where something is not allowed. So that's okay. That's just, we anticipated a little bit more on our expenditure side and didn't hit that mark, but everything was covered. Then under the state grants, our original budget was $16 million, and we actually ended up with $19 million. And the big portion of that was from our ESIT program, which is early support for infant and toddlers. And each year there's a change to the actual the count of the children, child count, and the rate. So we actually had an increase in both of those mid-year, which is why we ended up actually higher than 100% for the calendar year. Another funding stream of note is the Medicare and Medicaid dollars. We anticipated $11 million, and we came in at $8 million. So that is a decrease of over $3.3 million anticipated billing to Medicaid and Medicare. That is a direct result of billable services and the number of clients we may have, either in the treatment services program or billable for our HIV clients. So numbers are a little lower than anticipated in the Medicare, Medicaid. The next category, interest, was budgeted at $180,000, but we actually ended up at $437,000. Big portion of that is the interest rates for savings went up. And so at the time the budget was developed, we were still going off of the very, very low rate. So there's been an increase there. And as our unassigned reserves increase, then our balance in our cash account would also earn more, just based on an increased balance. Another item to note is our foundational public health services, budgeted at $4.2 million, actually ended at $4.6 million, so 109%. Foundational public health services as a whole has increased annually, and each year it runs July through June. So we had a little bit of unanticipated or unbudgeted increase in FPHS dollars. So overall, that brings us to the 96% in the funding. And then on our expenses, $53 million was the budget. We came in at $50.8 million on actuals, and really the only decrease or underspent would be in the capital equipment. We had some projects that we did not complete in 2023. So there were dollars there that were part of our local dollar that we would have spent, and those did not materialize. We only spent $685,000 instead of 2.5. So that is part of the reason we have some unassigned increase at the end of the year. Overall, the agency did have a fund balance increase of 773. We do have 5 divisions in the organization. We did have 3 divisions that ran a surplus. One division had a deficiency or needed local dollars, and then 2 programs within another division also needed local dollars. But overall, the health district was able to cover that shortfall and has a net of the 773 that goes into reserves. Do want to note on the 2023, this is as of the best numbers we have to date. It is subject to the audit. Our books are still technically open through the end of March, so that we can accrue anything back that may be pertinent to 2023. So I don't anticipate this to materially change. The story's still going to be the same. We have a fund balance increase, but there might be some small adjustments made through the annual report preparation and or the audit review. So just want to mention that. Any questions on 23's budget before I move to 24 briefly? Okay, great. So a little bit smaller, a little easier report to read, less columns for 2024. February, we would expect, if we were right on target, 2 months out of the 12 months of the year, we'd be at 17% for expenses and revenue. So under expenses, we actually flip-flopped the report from the last year. We had funding listed first and then expenses. Just want to note that we're starting out the new year with listing the expenses and then all the funding streams underneath. So our expenses were actually at 14.6% rather than 17%. So we're well within our budget year to date for expenses. A little bit low on our capital outlay. That's not going to happen every single month. So that's primarily the reason for it being only at 14.6%. When we get into the funding, all of our different funding streams, some of them are advance payments to the health district. Others we have to bill after the expenses occurred and get reimbursement. So those first 2 categories, federal indirect and state, you'll see there's very small dollar amounts there for the month of February. And that's because we haven't prepared, or at the end of closing February, we prepare the billing to the different grants requesting reimbursement. So that'll be reflected in the following month. So we're low on those revenues right now. Medicare and Medicaid is current. We do bill that weekly, and then we accrue for the difference at the end of the month. So as I mentioned, in 2023, it's coming in a little bit lower based on our counts with client activities. So that's under the 17%. However, we do have Spokane County contribution. That's one of those advance payments that we receive before all the expenses are spent. And so the county has contributed their first quarter assessment for the health district, so we're right at the 25%. And then the public health appropriation, state of Washington, that comes in twice a year, July and December. We accrue that, so we won't see the $2.8 million until at least mid-year. The one right above that, though, the foundational public health services of $5.9 million, we have 62% of what we anticipated. So we have received the first half annual allocation, and then if you look at January, there's $763,995 that we're able to carry forward from 2023 into 2024. That grant actually runs from July 23 into June of 24. So we had unspent FPHS dollars that moved into 2024. So that explains why we're more than 50% in that category. So overall, through February, even with not billing yet the federal indirect and the state, we are at a surplus of $765,000 year to date for 2024. That does reflect that our unassigned reserves is 24% based on where we landed for 23 and then the 2 months in 2024. And so the final number for reserves is $18.3 million. And then again, I just left the note there that subject to change, the reserves and whatever our final number is in 23 will be reflected in 24. And that would be my financial report.
Any questions for Kim?
Thank you.
Thank you. Okay, that leads us into our health officer report. So Dr. V, you're up.
Good afternoon, everyone. Today, I actually have 3 items to update you on. 2 of them we've heard about over the last few months, and one is an update of an ongoing activity that I want you to be aware of. So let me start with the first one, which is where we with the Shigella outbreak that we have been managing. If you recall, we started with the first case at the end of October 31st last year. And if you look at the distribution of the cases, we did have a number of cases, particularly closer to the last quarter of the last year. Currently, we have about 201. We haven't had a single case in the last 2 weeks. I'm not going to jinx it, so we're going to wait until we have at least 30 days to then determine whether we can say the outbreak is over. And the reason why I want to point this out is because given the high-risk populations in which this outbreak started, the fact that we only have, 201 cases, a lot of cases, but compared to the number of cases that we've seen in other parts of the state and other parts of the country where the cases run to the thousands, this has been a major containment effort. And at the end of when we talk about measles, I'm going to talk a little bit about how we've done that. So this is where we're at right now, keeping our fingers crossed. By the last few weeks, most of the cases were in the community. If you can see initially the green bars, which is our homeless population, which was the epicenter at the beginning, that has also been contained. So I do want to say thank you to all of our partners in the shelters who continue to be on top of this every day. We just continue to meet with them every other Monday, and the team continues to do walkthroughs just to help our shelter partners make sure they're following all the best practices. And if we just look at the numbers, like I always say, the data usually speaks for itself. That means they're doing a great job. Good news is most of the cases that we saw at the trail end of the curve did not really require hospitalization, which basically tells us that we've also been containing this in vulnerable populations, which is one of the key issues because Shigella and people with pre-existing conditions in vulnerable populations with issues such as malnutrition, exposure, tend to be more severe, which is what we saw initially in the homeless population. So with that, I'm going to move very quickly on to measles. I only have one slide on that one because I don't have much to say other than we still have the original 3 cases, index case, and the 2 household exposures. We have not seen any other cases despite all the surveillance in the community. And we are waiting the 2 incubation periods, 21 days each. That will bring us to April the 13th, at which point, if we have no cases, we will declare this outbreak over. And I'm going to stop here and just remind everyone that right now we do have outbreaks of measles in at least 17 different states and all over the world. Actually, according to the World Health Organization, measles have gone up 79% in the last year. And part of that is because during COVID, about 62 million doses of MMR were either not administered or were deferred for administration later. So we have seen an increase in many parts of the world. So I do want to stop here and say that we should say thank you to the team here and all of our community partners, particularly our EPI, emergency response, immunizations, communications, environmental, public health, etc., because this was a multidisciplinary approach. This is the 3rd time we use this approach, monkeypox, Shigella, and measles. And I think if you look at the longitudinal data, the fact that we're approaching it is working. But we can't do it on our own. We can only do it because our partners are lockstep with us. And that's a lot of people in this community, so I want to say thank you to all of them. It's the only way you can do these things. But I did want to stop and say, highlight that for folks that are listening to this meeting, because the fact that the numbers are basically non-existent compared to our jurisdictions doesn't really happen by accident. There's a lot of work that goes behind that. So with that, I'm going to move on to another topic that I wanted to provide you an update, which is the Fentanyl Roundtable, which is a group I have been leading, and I'll give you the history of it for a few months. And it all started last year when we were looking at all of the numbers, this 2023 summer, late summer. We're looking at all the numbers and the increasing cases. You have that article in your packet, and I know more recently the numbers that are in the first paragraph have been quoted in various meetings, so that's where the numbers came from. And the rationale behind this is, as I was having conversations with providers, it was not a concern, but a need to have more information about it. So typically what we do is we use as many educational outlets as we have. So I wrote that for the County Medical Society, which all of our providers get, and also did a number of presentations in the community, and I'm still doing some of those. But shortly after that, I did receive a call from Senator Cantwell's office that the senator had seen some of the numbers, had seen some of the data, and wanted to come and have a community conversation, listen to the community, what are the issues and what can we do about it. So we put together a discussion, a roundtable, which the senator asked me to moderate. This actually was in the spokesman. And that brought together a large number of members of the community in many areas. And at least I think it was the first time that we had some of these folks at the table. That was by their own assertion. And we were just talking about what is it that we're seeing and what does that mean in your universe, or where you work, or where you're at. And as we were having that conversation, I was taking some notes. I look very serious there, but it's because I was listening. And I was listening actually to the story that was being told of this lady who had someone with lived experience who had one child taken away. Second child, when she went to Maddie's place, was able to kill the child. Now she's a peer counselor, doing very well. I just saw her at the parade the other day. But as I was listening to that, there were a number of themes that kept coming up from the universe of all participating. So these were some of the issues that I kept hearing. Not saying that I'm an expert on any of these issues, but it caught my attention. And it caught my attention because a lot of people were talking about the same thing, but slightly different ways. So for example, we don't have enough facilities or bed capacity, and I will ask, what kind of beds? Capacity for what exactly? And there was a lot of interpretation on that. Second was, we don't have enough providers, and many of the providers that are there are not reimbursable services, which it is true. So we talk a lot about licensing requirements, et cetera. Use of other types of tools. Social media came up a lot of times, and actually that kind of narrowed a lot between K through 12 and younger populations. So we do have some conversations with the schools. We also heard that there's some specific segments of the community, as well as some specific segments of the population with higher impact of this. And one that was kind of interesting is that once a person has an encounter, whether it's law enforcement, justice system, emergency room, EMS, fire department, there's no continuity after that. It kind of fall off. And we're going to talk about that in a second. Now, we also talk a lot about Narcan, and I do know that the health district is one of the areas that we have ramped up over the last year significantly, not only distribution, but our medical reserve corps goes around doing training and certification for community-based organizations or others that need it. So I do know that a lot of things are happening there. Now, availability of treatment services. And I go well, we have the largest one, so, but not everybody knows that. And I think going to the program that was being talked about, not everybody knows where resources are. And then last but not least, In addition to the traditional substance use programs like ours, which is the largest in the region, there were some what I would call community-based, more niche providers that had interesting models like Peer Spokane. I'm sure you're aware of it. They do a great job, and these are all people with lived experience that have become counselors. Not certified counselors, that's why they don't get reimbursed, but we'll get back to it in a second. And Maddie's Place, which is for newborns, basically, and their families. And if you've never been there, you should go. And then Compassion Addiction and others. So as a result of that, I actually lean over to the senator and say, I have an idea. How about if we take this and keep running with it and see what we as a community can do if we identify some commonalities of purpose? I said, that sounds good. And I said, well, I will probably come back with an ask. Don't say that. But I did. That was the genesis of what we know now as the Fentanyl Roundtable. The next meeting is April the 10th. This group meets every 5-6 weeks or so. And it's fairly broad representation. The invitee list is about 46 people. That not everybody shows up every day, otherwise we'll need a very large auditorium. But we do have a good selection of all in the community that have some contribution to make about this particular issue. And as we spin off some smaller work groups, we will have even more of that. For example, as we go through this, I'm going to tell you that I'm going to separate K through 12 because our school partners are doing a good job, but we need to keep working on that. So as we look at this, and this is straight from the first meeting. By the way, the meetings are recorded, and we have meeting notes, and all the presentations are electronically saved. We have all of that. Actually, Madison goes with me and records, and we make sure that everybody has access to the information. But this was directly from the agenda of the first meeting. And I want to highlight a couple of things. First of all, work community. The reality of the matter is no single person, agency, or organization is going to tackle this. It's the way that is. But we as a community can do a lot. But we can only do a lot if we know what we're doing and why. So that was a concept of narrowly defined action items. Example, I know I'm not going to stop the fentanyl flow in the world. I wish I could, but I don't have that capability. But what is it that we can identify? 1, 2, 3, you know me, I don't do not boil the ocean because that never works. Get a couple of things that we as a group can identify, get the resources and move forward and have an impact. And the impact is going to be how do we actually prevent overdoses, help the people, help the families, and help the community. They continue, not just one person or two people. So after this first meeting, we narrowed it down from whatever it was to this, and then we further narrowed this down to 3, which is a great number to have. Reimbursement keeps coming up, and the question was, what do we mean when we talk about reimbursement? So I'm not an expert on reimbursement, so we did have, thank you to Partners at Providence, they did deploy some of the reimbursement experts to give all of us a crash course on reimbursement for mental behavioral health and substance use. And one of the things that you find out is traditional healthcare, because of reimbursement, is not a good place for substance use treatment, which we went like, aha, that was an aha moment for all of us. Second is, I heard this a lot, judicial system is broken. I said, well, what part of it and how? No one could actually point out to it, but the good news is we do have members of law enforcement and justice. We have 2 judges that volunteer to give all of us a crash course on how the judicial system works in Spokane County, both city and county, which I'm not an attorney, I don't do that, so that was a lesson for all of us, and actually identify everything that the justice and judicial system is doing and where the dropouts are that we as a community need to come in and help bridge that gap. This was interesting because we did find out, and actually have tons of information about it, that we're doing as a community a lot, but it's not coordinated. And not single person in this county knows exactly everything that's being done. Nor there is inventory either. There are a lot of inventories. None of those inventories is complete. So that is something that we're going to talk about in a second. Then, of course, K through 12, we have a lot of concern that a lot of the marketing or availability is being targeted to younger populations. I was at the Redeem Foundation event last night, the Spokane Alliance for Fentanyl Education, and one of the speakers was a young lady that managed to really not only combat this issue but succeed at this point in time, was saying that her concern is we're seeing kids 10, 11, 12 years old, which is K through 12. Healthcare wants to be a partner, but they're limited on what they can do immediately. And emergency medical services will tell you that they're a little bit frustrated. They go and revive someone, person goes away, they may see it again next week, etc. So we started doing some research around the country and found a number of examples. That orange binder is just my notes from the meeting. We do have a whole electronic file. We went around the country and looked at who's done something that we could learn from, because we don't have to reinvent the wheel. And this actually, the state of North Dakota did a really good job of looking at increasing the availability of providers, particularly what the non-traditional providers. They developed a curriculum for these providers. They're not licensed, but they have the training and the certification and the continuing education to remain active and through the legislature made their services reimbursable. And as you can see here, they have, the last couple of years, got out another 60 providers that added 4,500 people to the rosters of people with services that did not have services before. They continue to do that. So they have joined us a couple of times and are going to join us again when we start to talk about reimbursement and legislative action, because at some point we probably have to explore that. So that was one of the models that we look at. Then we looked at Kentucky, state of Kentucky, and I don't want you to pay attention to all of these 10,000 numbers. I want to highlight something which is in their assessment, and it's something that we started to see a common thread here. Anyone involved in substance use is a very complex individual with a lot of issues, not all of them related to substance use. There could be mental behavioral health, there could be housing, there could be food, there could be transportation. I mean, there's a long list of issues, and if we only address one, the recidivism rate is 70 to 80%, because we're not addressing the continuum of issues, we're just looking at one. And the way I look at it is, a doctor, you come to me and you have fever, and I take care of your fever, but I don't figure out what's causing the fever. You may have an abscess, which eventually is going to blow a hole in you, and I didn't take care of that, which is going to be worse than the fever. So we do have a lot of data from the state of Kentucky that followed a similar path, narrower than the state of North Dakota. And as we were doing that, we started to distill this down to like 3 key areas. Key area number 1, continuum of care. You cannot just address one thing. If you address one thing, you're not going to succeed. And that was clear from all of the literature that we looked at. Second, at least in this community, we have all these drop-offs. I call them drop-offs. One of our judges that is part of the team calls it cliffs. But what it happens is you have an interaction with law enforcement, justice system, emergency room, emergency services, fire department, et cetera, et cetera, et cetera. What happens after that? Even in the justice system, our judges will tell you you're frustrated because they have 2 options, basically. 3. Therapeutic court, jail, or let you go. If they let you go, they're going to see you again, and that's their statement. They send you to jail, that's not going to address the issue that you have. It's just going to keep you on the street for a few days. Then this one is kind of interesting, and it's something that we in Spokane have worked on, because we've always looked at, and we call it hotspotters here. individuals that are high utilization because of complex issues. And I know that wearing my hat as HSSA, we've actually funded the hotspotters multiple years. So this is something that all communities identified as one of the areas that if you're going to succeed, you need to look at first. So the question was, how do we address a high-impact individuals, align the continuum of care, and prevent the drop-offs or cliffs? So I took all three into one question. So this data from Camden, New Jersey, which was published by the Kennedy School of Government, Harvard School, the Harvard University. And there are a lot of places that have literature, but this one is kind of interesting. And I just want you to look at that graph for a second. These are high utilization individuals. And then if you take one of those individuals and map it, this is what it looks like. So encounters with healthcare, encounters with justice system, a lot of other issues, incarceration multiple times, each time longer. Started with someone that had a quote-unquote normal life. Something happened. Behavior changed. Drugs use started. And from there on, it just snowballed into a constant issue, one issue after the other in all areas. And every time there's an encounter of those, one of the things that a lot of people will tell you, there's a high cost. Not only in terms of financial cost, but also societal cost and individual cost for the person. Like at the Raise Redeem Foundation last night, we had a young lady whose trajectory was about like that. Now, she had supportive family with resources and access and knowledge. So at this point, they've been able to get her back. But that's not true of lots. Because even those that have access and knowledge, because I've talked to the judges and I've been to their courts, even those that have access and their whole family is there, they will just not look at them in the face. They just don't want to hear about it, they don't want to know about it. And the reason for that is not because they're not nice people. The reason for that is because the drugs that we have on the street are so highly addictive that these folks are terrified of the side effects of the drug. And if you have seen one, you will know what I'm talking about. So, we came across, thank you to our friends from the Citizens for a Safe Spokane, which is actually all faith-based organizations have come together a couple of years ago. They connected us with the folks from Bexar County, Texas, which is San Antonio. And this is a model that has gotten a lot of press. I know that other counties in San Antonio, like Houston, is trying to do it. I know Boston is looking at it. I know New Hampshire. There's a whole bunch of places that are looking at similar models. But what this is basically, they looked at, so what is the issue? And how can we do a triage and intervene short term and then have a long term process? So they created what is called the Restoration Center. And I'm going to show you an image of it. But what it boils down to is, remember those encounters that you have? One of the issues is where do you go after the encounter? And is that the best place for you? So they figure out that if there was a place for law enforcement, for example, to bring these individuals that are in crisis, and those individuals are brought into a facility immediately that addresses the issues, whatever the issues are, in a comprehensive manner, with the thought process of detox, recovery, reintegration into society, then you can succeed. So, which is what they have actually done. And it all started with law enforcement, bring people that were in crisis in, and the Restoration Center is open 24 hours a day, 365 days a year. No one is turned away, and police officers can bring someone or whomever else is they encounter, and that disposition will be done within 15 minutes, including 100% mental health evaluations for all that come through it. So complicated, but Look at that, community reintegration, and they have thousands of success stories. This is what it looks now, like now. Restoration Center started over here. By the way, they didn't start with that building. They started with a small triage place, just for a small number of people, get them on the street and get them in the process of moving forward. And if you think about it, this Restoration Center, if you go to the previous slide, let me see if I can do that. Yeah, no, that one. This one. You have everything from detox, sovereign units, inpatient care. Now they have primary care, prenatal care, and all of the services of counseling and mental and behavioral health assessment, job training to reintegrate you back into society. That's the final model now. It took years. It didn't do it in one day. But they have all of those that started with one building. Now you have housing. And the reason for that is many of these folks that are coming off, it is difficult for them to move into the neighborhood they used to live. It's just. Huh? But yeah, the sobering, they have a sobering unit here. Yeah. Have gone through treatment, and they have one more stage before they can go away. But then they can start to do job training, skill training, get degrees if needed. And by the time they're released back into society, they're productive in society without any issues. Now, they can always come back. And one of the reasons why I mentioned primary care and prenatal care is because one of the observations was with pregnant women, pregnancy itself sometimes could be the triggering effect if they don't have access to the resources. That's why they started prenatal care. Why primary care? Because I don't have anywhere to go when I have COVID. I may end up back on the street. Yes, sir. Well, yes, and that is correct. But the concern was that even after they went through incarceration, when they were released, the recidivism was about 70%. People would come back. So the question was, do we house you there, or do we put you somewhere else that we don't see you back in jail? And the bigger county is 1.8 million people, so a little bit than we are. But the important thing is, and I'm glad you brought that up. Example, if I pick someone on the streets and I'm a law enforcement and the person has an injury in their leg, what am I going to do? Bring them to the emergency room. You have to. So they can stitch it or whatever it is. Over there, you bring it over here and they will take care of that. They have the acute services to do that. Not everybody can go there with depending on their clinical condition. But one of the things, and they have a lot of videos where police officers are the one saying, this is great because now we have a place to go. They never say no. We leave in 15 minutes to go back to patrolling the streets, which is what we're supposed to do, as opposed to sit in the emergency room for 14 hours. So yeah, there's a lot. I mean, this is a complex model by now, but there are bits and pieces that I think we as a community can start to aggregate. So these are some of the results, and what it boils down to, they have used cost avoidance as a business model, which kind of makes sense. Basically means instead of spending X thousands on emergency room, it's about $350 per patient that gets diverted to the restoration center, as opposed to $12,000 for the emergency room. And I have a lot of data that just to give you some ideas. So they've been saving about more than $10-12 million a year in real costs that they used to have that now can be realigned, because this is a good example of the different costs. This will be $2,200 if you send to jail. It's about $6,000 into the emergency room, et cetera, et cetera, et cetera. It's about $350 standard per individual. Now, mind you, by now they have about 150 employees that work in that complex. So this is not something you can do like tomorrow. The police officers are very supportive of this particular metric, which is that they want to be out there serving and protecting. They don't want to be in the emergency room babysitting someone. So as we look at all of this various models, when we meet next on April the 10th, we're probably going to be looking at 3 potential key action items to explore. Action item number 1, really figure out what is it that we have as a community. The good news is our data center has already started the process collating everything that we have. Of course, there are consultants, the ones that developed this model now have a consulting group, and we've looked at their business model, but we as a community can gather a lot of this ourselves, and our data center is the best place to have the repository for that. Once we do that, and that will be finished fairly soon, we can go and say, okay, we're missing the following, and then go and target that, as opposed to send surveys and surveys and surveys. They're gathering everything that we already have from anyone, and that will tell us what the gap is. Second, we do need to look at this high utilization individuals. The HIPAA issues and so on and so forth, but the reality of the matter is that this individuals, maybe 5 assessment ballpark, we may have like 60 people in town that are about 80% of the cost. So since we do know that, why don't we, instead of patch you and send you out, why don't we bring you in? Do a short-term triage pilot project and determine whether it makes sense for us to have this kind of model or not. And if so, what does it cost? And what is the advantage? And what are the benefits? But the question is, when we bring these folks in, it's not just to put them on treatment. It is to really get to what is it that we need to do for you that is going to get you on the other side. And the other side may be now, or maybe 6 months from now. One of the things that we know is that most facilities where you have short-term, like we do, 28 days, the recidivism is astronomically high. Most places will tell you in about 90 days for that brain chemistry to realign itself a little bit. So anyway, so this is what we're going to talk on April the 10th. I'm looking forward to the meeting. Thank you to the MAC. We use their Gilkey boardroom, which is neutral place, free parking, wonderful facility, and they've been very gracious to host us, because that allows people to come without being concerned about where they are. We do have a lot of folks with lived experience that participate in this group, so we want to be sensitive to, sometimes they have a little bit concern about facilities and so on and so forth. So I'm going to stop here and see if there are any questions about that. Sorry, I went really fast, but I'm summarizing the last few months. Yes.
Well, Dr. B, I'm really excited that this group is really getting active. So can you just tell me who from the county is participating? Is Justin Johnson part of the?
Yeah,
okay,
and there's
great.
2 other people that he assigned, and there's a couple of people from the city. And by the way, I should say that we do have members from county, from city, from police, sheriff, justice, et cetera, because they're critical components. Now, granted, you know how meetings are, not everybody shows up to every meeting, but everybody has the same information. We make sure everybody gets the same information, and we do kind of like recap a little bit. And if you notice this presentation, this has been the cadence of the group. We went fact-finding, and the rationale behind that was, if we're going to talk about something, let's not just make a general statement. Let's make sure we can define it very exactly. Like our judges can tell you exactly at which point we need to build that bridge and for what. So I think more to come, but our goal was to move at a reasonable speed. And as you can tell by this, we've had 3 or meetings or so with a lot of fact finding in the middle. We're going to our 4th meeting. We're already ready to move forward. And my goal is to make sure we keep moving at a really good clip. So we're not talking about it, we're actually doing it. Now, we're gonna have to bring lots of other people to the table to do this. And I am very enthusiastic because every time everybody asks me about it, I hear, oh, I heard about, can I? We go, certainly. So we've added people over the last couple months that heard about it from somebody else. We're not excluding anyone, we're just trying to keep it at a manageable size. And then we're going to split it in groups that are going to work on very specific issues and bring to the table everybody else that needs to be part of that specific issue. Because it's almost impossible to get everybody in just one group. Good question. Yes.
Oh, sorry. I just I know about is it Behar, Texas? Is that the name of how you pronounce Behar? Anyway, I do think they have a really interesting model, so I'm glad you guys are looking into that. And I was just going to suggest like Mike Sparber, if he's not attending, might be a good person just with the criminal justice reform initiatives that the county's been working on. And a lot of those are with the judges and the courts that try and steer folks in the right direction, with the therapeutic courts especially. So anyway, yeah, I just think this is really.
Actually, not to interrupt you, but I'm glad you mentioned that because we made that connection and he's invited to the next meeting.
Oh, okay.
So,
Good.
yeah.
No, I just think this is really important as the county and the city and have opioid settlement dollars. We don't have a ton of money, but we have some dollars that we'll be able to spend over the next 10 to 12 years. We also, county has mental health sales tax. It could be useful in different cases. You know, there's certain allowances for that. But I think it would be great to just continue this dialogue. My last piece was the data piece. I know there's been a lot of conversation around how can we get more real-time data. And is this group going to tackle maybe some suggestions back to like elected officials around how we could use some of those opioid settlement dollars to, because everyone's going to have to participate to share data. So just wondering, that's my last question was just around what you guys have been thinking about and what you might be able to recommend so we can have more data that would then drive better investment of strategies.
So that's a good question, and there's a couple of things. So there is what we're doing here at the health district. I know we have a dashboard and we have explored what else can we do, because we already get the EMS data and the medical examiner data. We got a lot of that, and the emergency room data. We got a lot of that, and that is validated, actionable data. We are exploring if there are other ways of getting additional data. One of the points that came up as we're doing some background research is I do know that, and we're going to talk King County today, this afternoon actually. We've been talking to others. We're very happy to talk to others and learn, because that's how you sometimes figure things out. But one of the things that we need to explore a little bit deeper, for example, with the King County model, because they use a presumptive or suspected, and apparently their medical examiner team has some options for more real-time testing, which we don't have in the community. So we want to explore that a little bit deeper. And knowing about testing, I know that when you do all the chromatography and all these things, it's going to take weeks, if not longer. Sometimes it takes longer than that. But we are exploring what else. I think with the data that we have, and one of the team members say it best, this issue is defined, we need solutions, but on a go-forward basis, it's important to be able to document what the impact is and how do we do it. So more to come on that. I know we're looking at that in the district, and the team is relying on us to actually do that. Good. Thank you.
Yeah, next up on our agenda is our legislative report. So Lola, tell us what happened in Olympia.
Oh my goodness, it has been just crazy. And I was not in Olympia, so that's going to be fun. So in your packet, there is a public health end of sessions highlight sheet. And so the first page and a half, 2 pages and a half, is the policy summary, and these are just policies focusing on public health. And then the last page is Wasalfo put together the budget highlights as well for everybody to review. So again, about 340 bills passed legislative and going to the governor for signature. And so most of what I'll be focusing on today are the bills that we've been watching because they were part of our ask. I only have one on here that I brought in to look at. It did not pass like the rest of them did, but it was really because we had intended, or we had kind of a high profile conversation over time on it. But so first we are looking at House Bill 1608, the expanding anaphylaxis medication in schools, and that was delivered to the governor on the 4th. House Bill 1899 was also delivered to the governor on the 4th. And then coming in a little bit late, but Senate Bill 6127 was the increasing access to human immunodeficiency virus post-exposure prophylactic drugs or therapies. And that kind of came a little bit late on the 8th. And so the one here is, one that did not pass was the modernizing the child fatality statute. And again, I brought it here simply because we've spoken about it so much, which is unfortunate, but there is always next year. Passed to governor on March 8th also was Senate Bill 5983, allowing the medical assistants with telehealth supervision to provide intramuscular injections for syphilis treatment, which I think is a really big deal. House Bill 5580, improving maternal health outcomes, which is really great news for Nurse-Family Partnership. That went to the governor on March 8th. And House Bill 1956, addressing the fentanyl and other substance abuse prevention education, which I think falls right in line with some of the information that Treatment Services was sharing earlier, and just trying to expand how we can do outreach. That also went to the governor on March 7th. And then implementing a statewide drug overdose prevention and education campaign delivered on March 8th. Excuse me. Senate Bill 5804, concerning the opioid overdose reversal medication, was delivered to the governor on March 8th as well. And that pretty much wraps up. I know this is very quick. But like I said, there was about 340 bills that were passed for signature this very quick session. So, any questions? And I hope you all were able to find yourself.
Any questions for Lola? Thank you very much.
Thank you.
And then that brings us to agency reports. So Kelly is going to tell us about National Public Health Week.
Yay! Yep, we have National Public Health Week coming up next week. We're very excited about this because this is our opportunity to showcase our employees and remind ourselves and the community about the passion that we have here in this building. And it's a passion for keeping people alive. I think that's a good thing. And that's what every single person in this building does, is come to work to help keep people safe and healthy and alive. So we're very excited. There's going to be stickers. I don't have them yet, but I'll make sure you all get one for the public health of it. This year we decided to do something interesting, keeping in mind the passion that employees have, and let them talk about that passion with 6-word stories. I don't know if you guys have ever heard of this, but 6-word stories started on a famous challenge issued by Hemingway that resulted in his famous shortest story ever, which was For Sale, Baby Shoes Never Worn. And all of the meaning that comes with just those 6 words. And so, knowing the deeper meaning that comes with that, we want to talk about what the work that we do here at SRHD in just 6 words. And it helps us not only understand the meaning of our own work, it's very reflective of what we do and why we're here every day, but also what our colleagues do. What is really important about their work? What do we learn about them? So, and developing these stories was extremely fun to work with our teams and watch them think about what they were developing. And we chose 3 stories that we'll highlight in videos. One is, oops, I don't know how to operate. Brittany, behind the numbers are hidden stories. Adam, joining partners, building trust, pursuing equity. And Barb, different isn't deficient, it's just different. And the videos give them an opportunity to dive into their stories and give you some background on how they came up with those or what they were thinking when they came up with those. Overall, we had 112 members of our team participate in this with 233 stories. So we had a lot to work through and choose from, and we have lots of different ways that we'll be able to highlight more stories, not just with these 3 videos, but also internally give our employees an opportunity to peruse everyone's stories and see how their colleagues think about their work. And then this is feeding into everything we're doing for Public Health Week. We do have a whole advertising campaign. It's a full campaign, newspaper advertising. We have mall banners, the digital campaign. We're also our own social media and also paid social media. We have a PSA that we'll be sending out, so we'll be able to use the video that we use to create our stories. We'll create a PSA out of those and get that out to television stations, and then also messaging on Spokane Public Radio. One of the key audiences that we have when we're thinking about National Public Health Week are those people in our community who are influencers or educated, who can talk about public health, that bring us into their conversations, that are involved in the community. And I think it's a good time to educate them. And so that's one of our big target market groups when it comes to communicating about public health during Public Health Week, in addition to internally and celebrating ourselves. So that looks like this with all of the digital components. What does social media post look like? The look of our banners in the malls. Spokane Valley Mall is one, and then River Park Square is the other one that we advertise. So in addition to that, get our city involved. We get out there. This is from previous years where we've tried to light up the city blue. We have our little Gumby, we call him, looking over the city. So you'll be seeing that. And then of course we get into the action and we make the blue lights on our building even brighter and show that we're a part of the community as well. And then we get our community involved in this. One way we do this through proclamations. A lot of you here see us next week when we come and visit you and talk about Public Health Week at your meetings. Many of our partners share out. We reach out to the people we work with on a regular basis and encourage them, and I encourage all of you to look for posts and share them next week so that we can get the message out and get more people watching our videos and learning about the passion that our employees have. And then Eastern Washington University always comes and visits because it's their day of giving also next week. So it's just a great time to partner, and we have so many Eastern grads here at SRHD because of their public health program. And yes, and so it's just a very opportune time to collaborate. And we also it's an opportunity internally to allow employees to mingle and celebrate each other. So we do events internally. One of them is an open house, and our board are welcome to attend. The second floor is hosting it this year, and they always pick a theme. And so this year's theme is Hollywood, but because on the second floor we have healthy living, they're calling it Hopewood. I don't know if you remember last year we had some news go out that HOPE stands for Healthy Outcomes from Positive Experiences. So the HOPE framework is based on brain science and behavioral research showing that positive childhood experiences improve lifelong mental health, even if a child has experienced trauma. So SRHD was among one of the first ever HOPE certified organizations, and they were certified by the HOPE National Resource Center at Tufts. So that was really exciting, and it's a framework that all of our programs can use and integrate into their work, so it really does make sense for them to do this fun Hollywood or Hopewood theme when they do their open house. And I think that is everything. Do you guys, yes?
Any questions for Kelly? Thank you.
Thank you.
All right, well, that brings us to board member check-in. So we'll just go around the room. If anybody has anything to add for the good of the order.
I guess I would just say I was excited today by all of the examples of collaborative.
All right. Well, then that brings us to adjournment. It is 2:36. Everybody have a wonderful rest of the day.